Ma'am, we are good to go.
Yeah.
Aarti?
Take turn. She said take.
Good afternoon, everyone. A very warm welcome for the Cutting Edge webinar by Pune Obstetric Gynec Society, along with Varanasi and Allahabad OBGY Society. So, our MOC, Dr. Aarti Evle, young fetal medicine expert, she is here. Yes, Dr. Aarti, please take forward.
Warm good afternoon to everyone. We are here for the 19th November Cutting Edge webinar. Pune Obs Gynae Society has been doing these weekly webinars for over a year now with different OBG societies from across India at the aim of spreading awareness and bringing to light different and various topics in the OBG healthcare. For today's webinar, we have two interesting topics. One by Dr. Vaishali Chavan, which is on fetal macrosomia, breathing difficulties. And the second is by Sangeeta Rai Madam, which is on intrapartum care for joyful motherhood. Today, we have collaborated with Varanasi OBG Society and Allahabad OBG Society. We look forward to a wonderful hour-long, interesting webinar, but we always start all our webinars with the blessings of the Almighty, so for which we would like to say a small prayer. I would request
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatrubuddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam.
Thank you very much. I would now like to invite Vaishali Chavan ma'am to introduce Pune Obs Gynae Society President Dr. Aarti Nimkar madam.
Thank you, Dr. Aarti. It's an honor for me to welcome all of you for this cutting edge webinar. And, with such big esteemed faculty who are here, and with one phone call, Varanasi Allahabad Society office bearers have agreed, and they are with us today, right from Ranjana ma'am, who is our guest of honor, Dr. Anuradha ma'am, who's our guest of honor.
Ma'am, waiting for you to join, ma'am.
Pardon? Aarti?
Sorry,
Yes.
ma'am.
And our speaker, Dr. Sangeeta Rai, our chairpersons, Dr. Manisha, Dr. Kumkum ma'am, Dr. Uma Jaiswal, and Dr. Avasthi, Dr. Ishita Avasthi, and with our own Pune Gynec Society team. This is Cutting Edge Webinar. Every Tuesday, we do this webinar between 4 to 5 p.m. And these have been started by Dr. Meenu Agarwal from 1st January last year. And our president, very dynamic president, Dr. Aarti Nimkar. It's an honor to introduce her. She's senior obstetrician gynecologist, main interest practicing safe motherhood with healthy babies. And she has worked as IMA president, worked in core committee of PMC during COVID pandemic. And she's, let me tell you, extremely into a fit person, into fitness, into dancing. She has won the Dhanvantari Award, Lokma 2021. IMA Pune Doctors Day Award in July 2023, and she has lot of other passions than obstetrics and endless energy to pursue all of them. So, warm welcome to Aarti Madam, and I request her, Aarti Madam, to welcome all our esteemed faculty.
Yeah, thank you, Vaishali. And I think there is no need of the so long introduction. Only senior gynecologist is okay. And I welcome, because we are doing this cutting edge with the Allahabad and Varanasi, I think Allahabad and Varanasi, when we hear, we feel something great and holistic feeling is there. And we are having the our guest of honor from the Varanasi, Ranjana Khanna madam and Anuradha madam. And I welcome you all, both of you, as a guest of honor. And we are now having the two sessions, that is the fetal macrosomia birthing difficulties. This is the little bit different chapter now Vaishali is going to talk on that. And everybody of us face the difficulty while delivering the big baby. So it will be the very informative talk Vaishali is going to give. And for her, the chairing the Manisha Gupta madam and the Kumkum madam for a session. Second session is an intrapartum care for the joyful motherhood. And Dr. Sangeet Rai is the speaker for that. She's the president of the Varanasi Organic Society and head of the department of the Varanasi College. For her, the chairpersons are the Uma Jaiswal madam and Ishita Avasti madam from the Allahabad and Varanasi Society. I welcome you all for this webinar that we are continuing since 1 year. And now our candidate is for the VP is the Dr. Vaishali, and we think that she should, you all are knowing her very well, and she is the very proper candidate for the vice presidency. Now, Aarti, carry forward it.
Thank you so much, ma'am. Now with this, we would move forward with introduction of our POGS General Secretary, Dr. Meenakshi Deshpande, and I would request ma'am to say a few words as well.
Thank you, Dr. Aarti. And yes, thank you and welcome to all the faculties of Varanasi and Allahabad and to this August webinar of POGS. We are having this cutting edge webinars every Tuesday, and we highly welcome you to this nice webinars which we are having with one gynec topic and one obstetric topic, a limited topic with a good discussion and full thoroughly, you go get along with these topics and scientific knowledge which is restricted to that topic. So we are getting good attendance also for these webinars. And yes, we would really like to have Vaishali as our Foxy VP for the next year. And we would like all of you from Varanasi and Allahabad to vote for her in the upcoming elections. And yes, over to you now, Aarti, to carry forward to the next topic. Shall I go along inviting the guest of honors?
Yes, Meenakshi, if you can welcome Dr.
Yes.
Ranjana Khanna.
So thank you. Can I have the slide, please? I would like to welcome our first guest of honor, Dr. Ranjana Khanna. Yes, this has been started by Dr. Meenu Agarwal also. Last year she was there and she has won with quite good number of votes. And we always hope that our Pune comes to the foremost in all Foxy activities. And yes, Vaishali Savan, we would like all of you to vote for her. I would like to invite Dr. Ranjana Khanna as a guest of honor today. And she is the past vice president of Foxy in 2017. She is the founder president of ISOPA Prayagraj in 2021 to 25. She is the ICOG governing council member from 2021 to 25. She is the executive member of National ISOBAP from 23 to 25. And she was the president of Allahabad Organic Society from 2013 to 2017. She was the organizing chairperson of the National Foxy Conference, Scientific Sangam Prayagraj in 2023, Obstetric Dilemmas Prayagraj in 2022, and BOH, the Triology in Delhi 2017. She was the organizing secretary of SAUMA in 2016, a faculty at national and international conferences, delivered the prestigious Dr. Prabha Malhotra oration in 2023, author of many articles and chapters in various books and journals. And she is the co-convener of Foxy GCPR guidelines on epilepsy in pregnancy. With so many awards to her cap, Foxy Achiever Awards 2022, Foxy Dhira Awards, Foxy DK Tank Reproductive Healthcare Promotion Trophy, received in AICOG 2015, and Foxy Smriti Mailan Award, Save the Girl Child in AICOG 2013. I welcome you, ma'am, to this dais of cutting edge webinars of POGS. I would request you to give your blessings and say a few words.
Thank you so much. Good evening, friends. At the outset, I would want to thank the Pune OBGYN Society for this honor. And it always gives me a great pleasure to share the dais with my very dear friend and senior, Anuradha ji, who's ex-HOD from BHU Varanasi. And it's actually, I bring you greetings from Prayagraj. And we are going to, proudly host the Mahakumbh this time in January. So all of you are cordially invited. It's actually a wonderful thing if you all come and experience. It's something to be experienced more than just hearing about it. So welcome and greetings from Prayagraj. But actually our society continues to be Allahabad OBGYN Society, though the name of the city has been changed to Prayagraj, because we have been registered as Allahabad OBGYN Society. So it has been my pleasure to meet and interact with Dr. Aarti Nimkar, President Pune. And I have often interacted with Meenu. And one thing I wanted to say, that Pune is now a city of stars. And we all know that in January, Sunita comes in as the president, Foxy, and Parag comes in as the ICOG chairman. So we have a combination of stalwarts now in Pune, and I'm sure Vaishali will be one of them soon to be vice president elect. So all my love and blessings to you, Vaishali, and all my good wishes also. And congrats to Pune Society for crafting this wonderful webinar. And I would like to congratulate Dr. Amol also, who's the scientific secretary. And all my Varanasi and Allahabad friends are here. And it's lovely seeing them always. And the two topics are very well chosen. Vaishali speaking on fetal macrosomia, birthing difficulties. Obstetrics is definitely my subject. So I am a dedicated obstetrician. And the second topic is equally good, and that will be talked by Dr. Sangeeta Rai, who is at present the president of Varanasi Society. And this session is going to be chaired by the secretaries of both the societies. We have Uma from Allahabad and we have Ishita from Varanasi. So I am just looking forward to hearing these talks. And once again, I want to wish Vaishali all the best for her endeavors. And I wish this webinar a dramatic success. Thank you.
Thank you, madam, for your wishes, for your blessings. It's always a great honor, such great pleasure to meet you at all the conferences, to meet you and sir. You're indeed so graceful and such a wonderful, warm-hearted person. And we look up to you. You are our inspiration. And your wishes and blessings mean a lot to me, sir, ma'am.
Thank you so
to
much,
all of us,
Vaishali.
ma'am.
With you,
Thank you,
definitely.
ma'am. Thank you, ma'am. Thank you so much.
Yeah, thank you, Khanna madam. And now I would like to introduce Dr. Anuradha Khanna madam. Can I have a CV, please? Yeah, Professor Anuradha Khanna. She's an ex-head of Department of Obstetrics and Gynecology from Varanasi. She is the president UP chapter of OBGYN in 22 to 24. And she's the founder president Society of Fetal Medicine in UP from 22 to 26. She is the ex-president of Varanasi OBGYN Society and the founder president of Varanasi Menopause Society. She is the organizing secretary of UPCOG 2009, AICOG 2012, and organizing chairperson of UPCOG 2019 and IMSCon 2021. Organizing chairperson of North Zone Foxy 2023 and organizing chairperson National SFM UP of 2023. GCM of ICOG and Indian Menopause Society. She's also the PG examiner and the MCI inspector. She is the FAML Fellow of Academy of Medical Sciences Awardee 2016. And she's the DJ Mukherjee IMA Awardee in 1977. She's got the WHO Fellowship Awardee in 1995 from USA and UICC Fellowship Awardee in 1994 from USA. Also, she's been awarded the Indo-Hungarian Fellowship Awards in 1992, the Indo-Netherlands Fellowship Awardee in 1998, and the Best Paper Awardee of AICOG 2010. She's got more than 120 publications in national and international journals and several chapters in many books. Along with it, she has guided 42 MD theses and 4 PhD theses. We welcome you. Give your blessings, madam.
Thank you, Dr. Meenakshi Deshpande ji. It's my pleasure to be honored in this August gathering and having very nice words from Dr. Aarti Nimkarji and from you also. And we have learned whole detail about our beloved Dr. Ranjana Khanna. And she has told whole the story of how Dr. Sunita Tendulkar and then Dr. Bhenewala and now our Vaishali is also entering in the same pathway to become a part of very senior members of the Foxy. And it is my profound privilege to have this. And it is very nice that every Tuesday you are sparing your time for this academic feast, which is very, very important. And I will request Dr. Sangeeta Rai, who is the head of Department of Institute of Medical Sciences, BHU, that ask the resident doctors 4 to 5 to attend these webinars also, as it is routinely will done. And always please share me the link. I will also like to attend it because always the academic is for the core of my heart, and revisiting and revising myself is the actual growth of us till we are living. So this is very, very important. And we all will be keep on changing. All our professors, our doctors, you all. But the journey to become more academically involved and having a good knowledge about the things so that we can treat our patients. The goal is that. And this is very, very important. I wish you, Dr. Vaishali, that you will have a very, very nice career in Foxy also. All the best for your academic vice presidentships, which you are going to opt for it. My all blessings from my heart to you. All the best. And thanks to all of you.
Thank you, madam. Thank you very much.
Thank you, ma'am. And ma'am, your presence, such a big esteemed stalwart amongst us, and to receive your wishes and blessings is a huge thing for us. And we are truly indebted with your presence. Your presence has enriched our webinar. Ranjana ma'am and your both your presence have totally added value to the webinar. So your blessings and wishes, thank you very much, and truly indebted to you. And ma'am, we will send you a link every Tuesday for the webinar, and we would like your guidance and advice about all this academic intakes and the topics that we will be doing. So thank you very much.
Thank you, Vaishali. All the best. Thanks.
Thank you, ma'am.
Thank you so much, ma'am. I would also like to wish Vaishali ma'am a very, very happy birthday. It's her birthday today. And with the
Oh.
birthday, it's a special occasion that birthday is also
yes.
there on this
I
fantastic
did wish
webinar
you
also.
I wished you on Facebook.
Yes,
And I
ma'am, you
was
did.
thinking also
Ah.
that I'll wish Vaishali personally.
Thank
Very,
Vaishali.
very happy birthday, dear, to you.
Yes, ma'am. Thank you.
Vaishali, you are
Yes.
so privileged. You are 19. 1 plus 9 is equal to 10. So
Yes.
this is the awesome number.
So
And
that
this
is
is the
number one.
birthday. This
Yeah.
is the birthday of Indira Gandhi.
Yes,
Yeah.
ma'am.
And this is the
My
birthday of
father's
my
birthday
mother.
also used to be on
My
19th.
mother is
Oh,
also the same.
really?
Today
Oh
I'm
my God.
celebrating. Now
My
she's
father
94 years
also.
old.
Oh,
Now
really?
she's 94. Yeah.
Happy birthday, ma'am. To
Yeah.
please convey wishes to madam.
So I'm very
Happy
sure
birthday,
that
Vaishali.
you
Happy
are
birthday.
going to win it. Yeah. I'm very sure, Vaishali, you are going to win it because you are 10. Yeah.
Yes,
Ah,
1.
that's number one.
number
Yeah.
one. Thank you, ma'am. Thank you.
Yeah.
This has been like really a great coincidence. The ma'am's mother, Ranjana ma'am's father, same day. I'm privileged.
We are 2 Khannas. We are two Khannas.
Yeah.
Always. We are there with each other. We are twin souls. As
Yeah.
I said, we are twin souls.
Truly, truly.
Yeah.
Yes, yes.
Wishing Vaishali ma'am again a very, very happy birthday
Thank
and
you, ma'am.
good wishes for the forthcoming election, ma'am. We are sure that you will definitely succeed.
Thank you, ma'am.
And all the elders' blessings are there, ma'am. Luckily, like you said today, a very, very blessed and very pious day. So, with this, can we go on to the first session, ma'am?
Yes,
For the first
please.
session, I would like to invite our chief guests, Dr. Manisha Gupta and Kumkum Tandon, ma'am. Can I have their slides, please? Manisha ma'am has finished her MBBS and MS OBGY. She is in Prayagraj from MLN Medical College, Prayagraj. She is Vice President AOGS 2021 to 2024 and she is the chairperson of Mission Pink Health. Can I have Kumkum ma'am's CV, please? Kumkum ma'am is currently working as consultant OBGY and actively doing surgical practice also. She's worked as chief obstetrician and gynecologist, Central Hospital, Central Railway, Prayagraj. Worked as chief health director, senior administrative grade at headquarter North Central Railway, Prayagraj. It's an honor to have both of you here, ma'am. I would request.
Dr. Kumkum is also the president-elect of AOGS. From January 2025, she'll take over.
Okay, ma'am.
Thank
Great.
you. Thank you, Ranjana.
I would request Manisha ma'am to introduce our first speaker for today.
Thank you. It's my privilege to introduce Dr. Vaishali and wish her a very, very happy birthday. 19th November is also birthday of Padma Shri Dr. Raj Baveja. I hope I am audible.
Yeah.
Yes, madam, yes.
Thank you. Now, Dr. Vaishali, as we all know her as a senior faculty, but still I'll introduce in short. She is a director of Cloud9 Hospital and Sanvi Clinic at Pune. She is a vice president-elect of Pune Society for the year 25-26. Then she has been honorary general secretary of Pune Society also, and she has many publications to her credit. And contributions in Foxy Focus also and chapters in international publications. Then she has received various awards, amongst which the latest one I can see is Legends of Gynecology Award at Kolkata,
Thank you, ma'am.
KICOG.
Thank you, ma'am.
Okay, now we welcome you as we all know you very well and wishing you best wishes for your election, Vice President.
Thank you, ma'am. Thank you for your kind introduction and for your wishes. Means a lot. So without taking much time, I'll just start with slide sharing.
I think ma'am is on her way to somewhere, no? She was in car.
Who is on the way?
No, someone was on the way.
I'm
My,
on the
That
way.
was Dr. Aarti Nimkar.
Aarti. Yeah.
Okay.
my screen
Now
is
she has reached.
I have closed the screen. I'm driving to the POJ's office.
so is my screen visible?
Yeah.
Yeah. Yeah.
So
Now you
my-
have to start sharing your screen because we can only see your CV right now.
you are not seeing I'm screen sharing. Are you able to see my screen?
Yeah.
Yeah.
Now.
Yes. So my topic is macrosomia and the associated birthing difficulties. And for all the young attendees who have logged in, so macrosomia and the subsequent shoulder dystocia is an obstetrician's nightmare. And that was the reason I wanted to speak shortly about it, about the various maneuvers which all young gynecologists should know if you are trapped in a situation where, yes, there is a risk of macrosomia and shoulder dystocia. So what does macrosomia mean? It implies when birth weight equals or more than 90th percentile for a given gestational age, or it implies if the birth weight is more than 4 kg for Indian population, or USG estimated fetal weight by abdominal circumference if the ratio is more than 95 percentile. And it's very really difficult to predict that this particular baby is going to end up with shoulder dystocia, because that is what we want to know. And the best ultrasound predictor is not expected birth weight, but it's the difference between the AC and the biparietal diameter. And if that is more than 2.6 centimeter, then yes, there is a risk of macrosomia and shoulder dystocia. So there are many risk factors it's important to identify, like past history of macrosomia, diabetic mother, big baby, maternal obesity, even age, elderly, primary, high parity, and so on, other risk factors. And the critical outcome, why are we so worried about shoulder dystocia? There could be morbidity, there could be various injuries, there could be HIE, perinatal death, increase PPH, third degree tear, fourth degree tears, and so on. And especially there are those damages to the nerves that occur at the brachial plexus, leading to ERBS paralysis. And even if there's an ERBS paralysis because of the brachial plexus injury, mostly by the year of 1 year of age, the baby recovers from it. And of course, there could be shoulder dystocia, hypoglycemia, and so on, baby long stay in NICU, cerebral palsy because of birth asphyxia, and so on. So there was a concept that whether we should, is there any benefit of induction of labor before 39 weeks of pregnancy, so that baby, with post-term babies become bigger, and then the risk of shoulder dystocia is there. So there have been a lot of RCTs, and finally, NICE guideline have shown that there was no strong clinical evidence to support induction of labor, preferable to expectant management. So the whether to go in for induction of labor to avoid allowing the baby to become bigger is something which is known as SDM, that is shared decision making, which you need to explain to the patient and the family, and then a joint decision can be taken. So talking about this nightmare, the obstetrician's nightmare, and that shoulder dystocia. And in shoulder dystocia, what really happens is the failure of shoulders to deliver after the delivery of head, and within 60 seconds. So what really happens is the head comes out, and head is out, and you can visualize the head. And then there's failure of rotation, internal rotation of the shoulder. And this here shoulder gets impacted below the pubic symphysis. And this is the brachial plexus which gets injured. And later on, all these maneuvers we need to do to disimpact this shoulder which is lodged in. So failure of shoulders to deliver after delivery of head within 60 seconds is what is known as shoulder dystocia. And in shoulder dystocia, additional obstetric maneuvers are required to deliver the fetus. And there is lot of maternal morbidity, fourth degree perineal tears as high as 3.8%, and brachial plexus injuries are visible. So how do you diagnose it? So diagnosis here, this is an animated video, and which shows the typical turtle sign that happens. So what really happens is the head comes out. Now we know, when macrosomia, big baby, and patient is in labor and she keeps progressing, and you are there assessing, you want to take her for section, but patient keeps progressing, dilatation improves, effacement improves, and you are there to deliver. And what really happens is that head has come out, as you can visualize. And with each contraction, the head is pushed out. You can see here, but the shoulder is impacted here, and shoulder remains here. So with contraction, head goes out, and again it recedes, and again it goes out. So this is an animated picture. What really happens in labor room is this horrific scene where you can see the head is trapped over there, and there is panic for the obstetrician, panic for all the surrounding people, and there's blood, screaming, patient in labor. So it's truly a nightmare. So first of all, what should you do? And then there is that we try to pull the head. So what are the things that should be done and should not be done? So these are the few tips. First of all, don't try to pull that head. As obstetrician, our first inclination is just towards pulling the head or somebody giving a bigger fund, more and more fundal. So this has to be avoided. You cannot pull the baby fundal. You should not give more fundal. What needs to be done? You have to pull the patient down and give a liberal episiotomy. Episiotomy as such is not going to relieve the bony obstruction, but liberal episiotomy will help us when we do those maneuvers, drain the bladder, and most important is call for help. Call as many people, because for doing all these maneuvers to relieve the shoulder dystocia, you need help. You cannot do it single-handedly. So you need your juniors, you need additional help, whoever is present in the labor room, the staff, junior staff, students, Mosi, whoever is there. Plus, you have to alert the neonatologist, the anesthetist if required. Take the patient to the edge of the table. Mac Roberts position. So, what is Mac Roberts position? It means simple hyperflexion of the thighs and abduction of the hips. So, with simple hyperflexion and abduction, the pubic symphysis also moves and there's more space created. At the same time, you should give suprapubic pressure. Suprapubic pressure in which way? You can see in the diagram, it should be given in such a way that the impacted anterior shoulder turns and comes into the pelvic inlet and the diameter, AP diameter reduces. So with simple Macrobert's position and suprapubic pressure, with these two simple things, almost 60 to 70% of patients shoulder dystocia reduces. You can see here, this is again animated. This is the flexion of the hips. And then when you do the flexion and abduction, automatically the diameter increases. The anterior shoulder has, which was lodged below pubic symphysis, is disimpacted and baby is delivered out. So how do you go about? So each step that is given here to relieve shoulder dystocia has to be performed for 30 to 60 seconds. If the baby does not come out in 60 seconds, you need to move to the next step. Next step is Rubens, and these are all maneuvers. These are maneuvers so that an impacted anterior posterior where the shoulder is impacted, we reduce the diameter, the biacromial diameter, we try to reduce and deliver the baby. So Rubens 1 is from outside abdominal wall, you push the shoulder to oblique diameter. Rubens 2 is you do a per vaginal examination and push the anterior shoulder to make it oblique. Then there's also Wood's corkscrew maneuver. What is that? Where you use both your hands and you try to change from anterior posterior AP diameter, you make it into oblique diameter. And these maneuvers actually, they are so simple that when a student is aware, a junior obstetrician is aware about these maneuvers, they can also do it. So this is Wood's corkscrew, where the baby, the anterior posterior diameter, by gentle traction and rotation, see there's rotation, and it is made into oblique, AP becomes oblique, and the baby is delivered. So this is the principle of in management of shoulder dystocia, creating these various maneuvers and making the AP position into oblique position. This is also when the posterior shoulder is impacted and the same position where both the shoulders are turned and AP position, anterior posterior position becomes oblique position and baby is delivered out. There is another maneuver which is known as delivery of the posterior arm, where fingers are put in, swept along, and the baby's posterior arm is swept anteriorly on baby's chest and gently pulled out. Once one shoulder is delivered, automatically the diameter reduces and it's easy to deliver the baby. There's another procedure known as Zuvinelli procedure. I think there's some disturbance with one of our faculties. Yeah. So Zavanelli procedure means the baby which is born partially out, it is pushed in again. And after baby is pushed in again, I think there's some disturbance in the background. Yeah. So the baby which has, this is very interesting to watch.
November end.
Meenakshi, I think your audio is on. So this baby has come out, it is pushed inside and then baby is delivered by cesarean. So this is Zivanelli maneuver. And there's one more maneuver, that is shoulder shrug technique. So when we shrug our shoulders, the diameter reduces. So same way you put in and digitally try to shrug the baby's shoulders so the diameter collapses. And the last maneuver which I'm going to discuss is the Gaskin's maneuver or position, in which patient is placed on all the fours, and which leads to increase to almost 1 to 2 centimeters in the diameter. And as the diameter increases, then the impacted shoulder gets relieved. So this is the mother who is on all four. And when the baby is on mother is on all four, gravity also helps. And with gravity against the pubic bones, the stretching of the pubic ligaments and the pelvic outlet diameter increases, and that helps in delivery of the baby. So this is also very interesting. And all these techniques actually are very simple. It's very important to do these kind of drills in teaching hospitals for a junior gynecologist or wherever they are available in conferences, because simple drills like this can save the baby's life and save the mother. So what is important when you anticipate or you know there's a shoulder dystocia? First of all, call for help, make a bigger episiotomy, widen it, Mac Roberts maneuver. So this is a helper mnemonic. Legs how? Mac Roberts flex and abduct. External suprapubic pressure in such a way that the anterior shoulder gets dislodged. Then rotational maneuvers, which we spoke about, like Rubin's or corkscrew maneuver. Removing of the posterior arm maneuver. And last is patient on all fours. And then you deliver. And whatever you do, documentation is very important. Keeping a neonatologist, NICU anesthetist nearby is very, very important. So it's very important that we should be able to diagnose and manage suspected macrosomia patient who may go into shoulder dystocia. And skilled obstetrician neonatologists need to be present. And prevention is the key. So it is important for prenatal counseling and during pregnancy exercise, maintaining the pregnancy weight, and so on, because obesity is one more factor which leads to macrosomia and shoulder dystocia. So thank you very much for patient hearing, and I seek all your support once more for the post of Vice President Foxy West Zone election year 2025. Thank you very much. I'll stop sharing my screen. Yes.
Thank you, Vaishali. That was a very nice and elaborate talk. I wanted to ask you one thing. Suppose a patient is in a labor room and you have called the anesthetist and neonatologist and everybody, but still all the maneuvers fail and you are not still able to take out the baby, and there's a risk of cerebral asphyxia of the child. Will you ever consider pubic symphysiotomy?
Madam, what you have brought about a very, very valid point. So, this is one of the recommended maneuvers, pubic symphysiectomy, cutting the bone. And it is really very, very morbid. I have personally not seen. It is recommended. So, I would like it's written, though I am a very senior obstetrician, but to do such a thing, I would also call for help. So that is where I would like to tell our young attendees that, ego should not, where you need help, you have to call for help. And going till the point of symphysiectomy, I would do interventions before that. And over a period of time, as senior clinicians, we can, diagnose that, yes, there is going to be an anticipated problem and better to go for a cesarean earlier or these maneuvers earlier. But so there's, as of now, today, role of destructive surgeries in modern obstetrics is not really there. And I have not seen any. Ma'am, can you elaborate about it? Tell us about it.
What I feel even if you have to resort, I think pubic symphysiotomy under anesthesia, though there is a risk of injury to bladder, urethra is more. But suppose it is not possible to do a section right there under expert hands, you can try for pubic symphysiotomy once your surgeon or some orthopedic surgeon is there. But then it is always better to try our manuals better than pubic
In
symphysiotomy.
modern
But I've seen
obstetrics,
only
there is
once.
no role of destructive operations.
It is not destructive operation. Pubic symphysiotomy is not destructive. You cut down a pubic symphysis and take out, widen
But then
the
I don't think the
outlet.
attendants are
But
going to
I have
be.
seen it only once. I have seen it Dr. Aruna doing it in Kamra Nehru, and the result was good, and the patient's recovery was also good. But I myself would not dare to do such a thing.
No.
I don't know about others. I've seen only once.
Do we need orthopedicians' help for doing symphysiotomy? Kumkum Didi? Whose help we'll need for doing that?
I think what they have recommended also that you can do baby's clavicular fracture and
Yeah.
reduce the diameter,
Yes.
then
That is more destructive.
yeah.
No, it's not so. I mean, if
is
you're
only for
forced
the
to, while you're
IUD
pulling
baby.
out the baby, sometimes I remember one of our teachers, Dr. V.K. Singh. Anuradha ji, you must be knowing Dr. V.K. Singh. She
Yeah,
was
I
there,
know.
Vimlesh.
Yeah,
So
very
she
nice.
was
Vimlesh,
delivering her
Dr. Vimlesh.
batchmate's wife. And that was a huge baby. She got stuck. And when she was pulling, the clavicle fractured. But in the end, all went well. And she told us the horrendous tale with tears in her eyes that I was in such a fixed situation because I was doing it in a nursing home. So I got stuck over there. She was past HOD. She's no more now in GSVM Medical College.
I will like to share my experience.
Yeah, Anuradha ji, sure.
Many of my patients, and in the BHU while I was there, I've managed by Mac Roberts maneuver. Many of only one patient, and at that time I was JR1 and my senior was JR2. JR3 has gone to take food. So no one there else in the room. We two were there. And it was a case, known person of a senior medical area manager. And the baby's head came out. We tried Mac Roberts maneuver. We couldn't be successful. Then I was a bit stronger than my senior. She said, Anuradha, थोड़ा सा तुम हाथ डाल के देखो तो. So मैंने हाथ डाला और फिर मैंने देखा कि वो हैंड है उसका. मैंने स्लिप किया जो मैनुअल अभी डॉक्टर बता रही थी वैशाली, to slip the hands, and while doing it there was humeral fracture. So I realized that and सब कुड़क से कुछ हुआ. But anyway, baby safely came out, and then I told the pediatrician what has happened. Then they called orthopedic surgeon to come along with pediatrician. I'm sorry, my dog is barking. And then we have what he said, no, don't bother, nothing problem. And he asked that just put a scale, 6 inches of scale, and it was put, and a tight bandage was done to the baby's hand, and then x-ray was done. It was very right inclined, and there was no problem. It was healed. Baby has grown very well. At present, the baby is in USA doing a very wonderful job. So no sign of any paralysis. So this is very important that we have to deliver the baby. Another thing is nowadays, as you said, you can reduce the head inside. If you have reduced the head inside, there why not to go for cesarean section?
Yeah.
Try to handle and try to get this and that. No, safely you do a cesarean section and you can extend the lower segment margins like a J and take out the baby safely. Good for
Exactly.
mother and the baby.
Exactly.
So I don't believe in pubic symphysiotomy because later on she will have a gait problem. Her gait will be changed and lot of bone infection. Why to go
Yes.
for it? This is my view, and still is so much long career of more than 40 years in IMSBHU hospital. Only one case that is the case with the fracture. Otherwise, all as you mentioned by Vaishali, that 60% are managed by this
Yeah.
management. That's very true. And one thing more, that macrosomia is there, and we are following up by ultrasound nowadays, the estimated fetal weight is there, the pelvis is there. So a good clinical checkup will avoid this unnecessarily tortoise like head coming and down. So we can go more elective cesarean. It's not at all unsafe. I
Of
don't
course.
believe in saying कि cesarean का रेट बढ़ गया है. अरे
हम्म।
रेट बढ़ गया लेकिन बच्चों की मोबिलिटी
बच्चे
तो
भी
कम
तो
हो
सेफ
गई
है, मदर्स भी
है ना.
सेफ है.
मुझे अभी भी याद है मेरे समय में मेरे प्रोफेसर
डेफिनेटली.
ने सीजर्स फॉर्सेप्स लगाया, वेंट्यूज लगाया. मैं बता रही हूँ अपना experience.
And we have to give the
बहुत
choice to the
complications हुए.
patient's attendant. And normally the
बहुत.
patient's attendant always choose ki, ma'am, do the surgery and take out the baby, and the mother baby both are
I
safe.
remember even myself.
हाँ.
I had second cesarean. मेरी मैम ने कहा कि नहीं नहीं तुम लंबी चौड़ी हो, तुम्हारा डिलीवरी हो जाएगा. बट यू सी कि जब वो फुल डायलेटेशन हुआ है, नीचे नहीं हुआ, एंड इट वाज प्रीवियस सिजेरियन. इमेजिन मैं कितने प्रॉब्लम में थी, मेरी मैडम कितने प्रॉब्लम में थी, और गैंग्रीन का केस लग गया ओटी में. ओटी नहीं मिल रहा, मुझे तो लगा मेरा रप्चर यूट्रस होने जा रहा है. दिस इज अ ट्रायल ऑफ सिजेरियन सेक्शन, बट गॉड इज ग्रेट. मैं बच गई, मेरा बच्चा भी बच गया. सो आई थिंक कि इतना हल्ला नहीं मचाने का. सीजर रेट बढ़ गया. अरे कितनी मॉर्बिडिटी कम हो गई है बच्चे की,
बहुत
और माँ
बहुत.
की ये भी तो देखना चाहिए.
मैम
सो थैंक यू
मैम
वेरी मच.
नमस्ते मैम,
हाँ,
आप हमारी
नमस्ते
टीचर हो.
हाँ
and
सुधे.
as my teacher, ma'am, today's scenario, we are the patient and myself, ourselves also, 1 or 2 babies. Why not go for safe method? जैसा कि
ऑलवेज
आपने कहा.
मतलब पेशेंट की जगह आप अपने को रखो
यस
कि
मैम,
अगर मैं
खुद को रख
यहाँ
के
हूँ
देखिए.
मेरे साथ क्या होगा. मैंने तो उसमें मैडम से बहुत कहा, मैडम आपसे मैं तब से कह रही थी सीजर कर दो, आप नहीं ट्रायल करेंगे, वजाइनल बर्थ करेंगे. एंड आई हैड सीन लॉट ऑफ प्रॉब्लम्स आफ्टर वेंट्यूज एंड लॉट ऑफ प्रॉब्लम्स आफ्टर फॉरसेप्स, कील एंड एप्लीकेशन ऑफ स्पेरालिसिस. आई डोंट बिलीव इन दिस इंस्ट्रूमेंटल डिलीवरी. आई एम वेरी
मैम मैंने भी अपने दोनों बच्चे सिजेरियन कराए हैं इसीलिए.
Ma'am,
हाँ
one
मैम
मैम कह रही
ठीक है.
थी निकल जाएंगे जल्दी से,
अगर
तुम परेशान हो रही हो. मैं कहा नहीं मैम, सीजर कर दीजिए. आई डोंट वांट.
हाँ, मतलब कोई इंजरी नहीं चाहता है.
नहीं
जितने
नहीं.
न्यूरॉन्स की हम बात करते हैं, ब्रेन्स की बात करते हैं, नर्व्स की बात करते हैं, कंप्रेशन की बात करते हैं, बेचारे बच्चे ने क्या कसूर किया कि जबरदस्ती में उसको ट्रायल देती रही.
जबरदस्ती
वेजाइनल
मैम,
बर्थ
सीपी के
सेक्शन.
चांसेस बहुत ज्यादा बढ़ जाते हैं जब जबरदस्ती आप करिए. अब सबसे ज्यादा तो
हम
प्रॉब्लम ये है.
कहाँ तो बात करते हैं कि निक लग गया, तो इस्थेमस सील हो गया, ये हो गया, वो हो गया. अब उसके बाद हम ट्रायल ऑफ सिजेरियन सेक्शन स्कार करें. पता नहीं, मेरे तो व्यूज में है कि नहीं, यू शुड गो फॉर अ सेफर ऑप्शन. Thank you so much for listening me.
Absolutely correctly said, ma'am. And what you have said is going to benefit all the attendees who have logged in today and to hear directly from such a great teacher like you. So, thank you for your inputs, ma'am. It's going to help.
Thank you, dear. Thank you.
One question from my side.
Sure.
Yes, Meenal ma'am, boliye.
Ma'am, can we assess the biacromial diameter somehow? Because especially in these high risk patients who have a higher expected birth weight, because now the ultrasound people are assessing the such small things like nuchal fold and so many things. I think if the fetal weight is above 90 or 95, at least in those patients, for a selective screening, we can ask the ultrasound people to tell us about the biacromial. At least we'll be able to know if the shoulders are broad. Then we have more chances of shoulder dystocia. So we have a documented paper also with us that yes, this needs
So
cesarean.
there is a guideline which I presented earlier.
Yeah, but in future maybe.
So the
We'll start
ratio
doing this.
between the abdominal circumference and biacromial
Yeah,
diameter
that one we have.
is
Yeah.
more than 2.6. That means
Yeah.
predictive of shoulder dystocia. What you are saying is absolutely correct, madam.
Yeah,
And it's a
because
very
sometimes the pelvic diameters are difficult to diagnose,
Yes.
to assess when the head is down, especially. And I think biacromial can be measured because they are measuring so many things nowadays.
absolutely right. Correctly said, Manisha. Kumkum ma'am, would you like to add anything? Kumkum ma'am is there?
Yeah, she's there. I think her laptop has hung up or something, no? There's
Yeah.
problem with the network, I think.
Yes, Kumkum
Yeah,
ma'am.
she's there.
I think freeze हो रहा है उनका. ठीक है. So should we proceed?
I don't know, I'm not able to see you.
Yeah. I think we can proceed.
Yeah.
Thank you so much, ma'am, for that session. And now, with your blessings, we'll go on to the second talk for today. I would request Meenakshi Deshpande, ma'am, to kindly introduce our chairpersons.
So
Hello. Am I
Can you
audible?
hear me? But I'm not able
Yes,
to see
ma'am.
you.
Hello. So after very interesting and a very good and very strong discussion of this topic of this birthing difficulties, macrosomia, I think we should go on to the next session now. I would like to welcome the chairpersons, Dr. Uma Jaiswal. Can I see her CV, please? Can
Ma'am,
I
एक
get a
short
CV
बोल
on the
दीजिए
screen?
secretary.
Yeah, thank you. Dr. Uma Jaiswal, she is the Honorary Secretary of Allahabad Obs-Gynae Society in 2023. She is aesthetic gynecologist and obstetrician. She is practicing more than 25 years and director of Shakuntala Hospital, which is a super specialty hospital. She is joint secretary of AOGS in 2019 to 20 and a member of FOXY. She is also a life member of AMA, a specialist in emergency obstetrics. Her field of interest is cosmetic and aesthetic gynecology and infertility. So welcome Dr. Uma Jaiswal ma'am to this webinar. Yeah, I will also like to introduce the second chairperson, Dr. Ishita Avasthi. She is a secretary of Varanasi Obstetrics and Gynec Society and practicing at Upahar Nursing Home. So welcome Dr. Ishita and welcome Dr. Uma. And over to you for the next introduction of the speaker. Welcome.
Thank you, Dr. Meenakshi. Thank you, EOGS and Dr. Vaishali for inviting me and giving me the opportunity. A warm welcome to faculties on board. Today's topic is very different from the routine topic. They are very important. How we can make our bottom care joyful, thankful, delightful, joyous, blissful, and glad. For this, we have experts among us, my dear friend, President Varanasi Obs and Gynae Society, and Professor and Head of the Department of Obs and Gynae BHU, Dr. Sangeeta Rai. The institution from where I did my MBBS and MD both. Dr. Sangeeta is very good. At present, she is HOD. Her topic today is intrapartum care for joyful motherhood. We want to listen from her. What is her experience and what is the welcome, Sangeeta, Dr. Sangeeta.
Thank you so much. Am I audible?
Yeah, you are audible.
Just let me share the screen, please. Thank you, Dr. Uma Jaiswal, for your lovely words. I would like to thank Dr. Vaishali for having me here, for giving me the opportunity. A very happy birthday to you on this day, and I wish you success in all your future endeavors.
Thank you, madam. Thank you.
I am really thankful to all the senior members of Pune Obs and Gynae Society for giving me the opportunity to talk here. Can you see my slide?
Yeah.
Yeah. It is full screen? Yeah. So I thank all the senior members of Pune Obs and Gynae Society for giving me the opportunity to talk on this very much common but yet very important topic. And I'm extremely thankful to Dr. Ranjana Khanna madam for her blessings. I always know her as a very, very sweet, simple, enthusiastic and a good academician. Thank you, ma'am, for blessing me. And also Dr. Anuradha Khanna ma'am, I know her from the very beginning since I have appointed as a lecturer in BHU. She is always my mentor, my guide, very, very active person, and she's always, always supporting me for all her blessings and guidance. So thank you, ma'am, for again blessing me here. Now, with this, I will start this important topic, that is
Dear Sangeeta, just to interrupt, you all invite them for Endometricon 2024.
yes, ma'am, and
You
thankful.
mention
ma'am.
this and
Yes,
then
in the
you go
last
for your
slide,
talk.
madam, I will invite madam.
Good, good, good.
Yes, madam. So today the topic is intrapartum care for joyful motherhood. We all know that intrapartum care, it is basically, it refers to the care provided to all the women during labor and delivery. It encompasses all the medical and emotional support that a woman receives from the onset of labor until the birth of the baby. Because we know that the second stage of labor, it is the most dangerous journey a woman ever undertakes, and it is the worst journey in the world. So as an obstetrician, it is our goal to ensure the safety and the well-being of the mother and both the newborn. And it needs effective intrapartum care requires multidisciplinary approach involving the obstetrician, the nurses, and other healthcare professionals. So why we started this? What is the WHO goal? The aim is that the labor and the childbirth should be individualized and it should be women-centered. No intervention should be implemented without a clear medical indication. Only interventions that serve an immediate purpose and proven to be beneficial should be promoted, and a clear objective that a positive childbirth experience for the woman, the newborn, and her family should be at the forefront of the labor and childbirth care all the times. I just wanted to again emphasize that we know everything, but always there is a gap, what we know and what we do practice. Whenever I take the rounds of the labor room, I always see that the women are in a single position. They are not allowed any food. There is no proper diet, no explanation. The respectful maternity care is very, very less sometimes. So this aggravates the anxiety of the patient, and it ultimately impacts the labor progress. So we need to emphasize our residents, the nursing staff, and all the healthcare professionals that we should decrease this gap, that we should have a respectful labor care and the childbirth. We should give emotional support from a companion of choice every time from starting the active phase of labor. The effective communication is very much important. What the patient wants, what are the questions we need to understand, and we need to answer all her doubts. The pain relief is very much important because their important thing is that the verbal analgesia, whenever we talk to the patient, half of anxiety is gone, and rest we can treat with the medications. Regular labor monitoring, documentation of the events, and audit and feedback, very important. Oral fluid intake should be allowed unless if we are planning for cesarean section. And mobility is very much important because it increases the progress of labor and shortens the labor. So this is important to understand, and let us go stepwise. So what are the concept of intrapartum care? And there are the three pillars, that is providing optimum pain relief, use of analgesics and antispasmodics, ensuring adequate uterine contraction, that is active management of labor, and close clinical monitoring of the labor events, that is maintaining a partogram. So now when a labor starts, we always expect that the patient should be delivered in the next 8 to 10 hours. And we have to approach the patient in all of the three concerned topics. So active management of first stage of labor or second stage of labor, what is the concept? It is basically started in 1973 by O'Driscoll and his colleague, and the reported advantage is the active management of labor shortens the labor, improve the obstetric outcome, and lower the cesarean section rate. Because we know that if there's a prolonged labor, if you're not monitoring the labor, the patient goes into exhaustion, delusion, there may be dehydration, ketoacidosis, and infection, and ultimately fetal distress. So both it is harmful to the mother and the baby, and we need to prevent this by good intrapartum care and having active management of labor. So what are the components? First, you have to identify that yes, patient has gone into active phase of labor, and then augment the labor by artificial amniotomy, oxytocin or prostaglandin if it is required, monitoring of the labor in a single sheet of paper with the help of partogram, and close supervision of the fetal well-being by auscultation or karyotocography. And yes, not the least, labor analgesia. So what are the components of active management labor in those patients when we are planning that yes, this patient will be going for trial of labor, and these patients should be kept for intrapartum care. In fact, all of the patients, they are important. We should give intrapartum for all the patient. But for active management of labor, the patient selection is very much important. There should be no identified medical or obstetric complications present. The primary gravida with a single-tail pregnancy with cephalic presentation with a spontaneous onset of labor, and also multigravida with a previous history of normal delivery. The gestation maturity will be between 37 to 41 completed weeks. And the admission, when you do the admission, you do the auscultation and a NST, and we should be reactive. So it is defined as the cervical dilatation. It is 4 centimeter and the effacement more than 50%. It should be always taken in case of low risk patient. Presence of anesthetist and neonatologist should be there, the consent, and during active phase of labor, the patient should be allowed in the labor room. What are the patients? We should not be considered for intrapartum care. That is high risk patient like antepartum hemorrhage, preeclampsia, the diabetes, polyhydramnios, oligohydramnios, cephalopelvic disproportion, malpresentation, and pre-labor rupture of membrane. So all these patients, they are received in labor room, but we are shifting for the cesarean section. So these are not the patient for the intrapartum care. So recommendation is the patient, when she enters the labor room, admission is to be given when the patient is in active phase, 4 to 5 centimeter dilatation. The companion of choice to provide continuous maternal support. The patient should choose her own position. She should choose upright position or lithotomy position or left lateral, or the patient can be mobile if there is no risk factors. Patient should be allowed food and drink, and the use of WHO partogram. Now we are using labor care guide to monitor the progress of labor. So what is not recommended? Strictly routine perineal shaving on admission, routine enema, NPO, routine IV fluid, routine vaginal douching, amniotomy, and routine oxytocin augmentation. So this is very much important that these patients should be considered. Coming to the medications, what are the medication protocol? Because when a patient goes into active labor, the pain starts increasing. So the medications protocol begins only when the patient is in active labor of 4 to 5 centimeter cervical dilatation. The uterine contractions come at a frequency of at least 3 in 10 minutes and last for at least 20 to 25 seconds. Head should be engaged. There should be no cephalopelvic disproportion, and patient may have show or draining. Now, coming to the pain management, we know that the labor pain can be managed using a variety of methods. I just told you about the verbal analgesia is very much important, 20 to 30% of the cases, but some non-pharmacological technique like breathing exercises, the positioning, hydrotherapy, acupuncture may help in decreasing the pain. And then we can use some pharmacological method, intravenous pain relief method, local anesthesia, or last not the least is epidural anesthesia. And the choice of pain relief depends on the factors such as women preferences, the progression of labor, and some medical considerations. So as per protocol, what are the medications used in intrapartum care? A combination of drugs which are used, they are provide effective care in during the pain relief, coupled with antispasmodic drugs which help in cervical softening, yielding, and dilatation to moderate the driving forces. And what is the advantage? It provides with the benefit of drugs aneurysm while at the same time restricting the doses of drugs to minimal amount commensurate with achieving progressive labor, while at the same time safeguarding the mother and her fetus against any major drug adverse effect. So this is the detail about the number of analgesia we can use isolation or in combination to optimize the pain. Oxytocin dip and prostaglandins, we have to augment the labor if the contractions are not adequate. And then for the pain relief, we can go with the Fortwin or Compose 1.5 ampoules each, or Tramadol 1 milligram per kg of body weight, or ketamine, initial 0.5 milligram per kg body weight, we can top up to 0.25 milligram per kg body weight. Coming to the facilitation of cervical dilatation, we can use either drotaverine, which we use more commonly in the labor room, and epidosin, tamilofilin, and hyoscine. So all these drugs in combination, depending upon the patient parameters, we can use these drugs to accelerate the labor. So how will you use this drug? The patient, whenever you are using, you have to establish an IV line and then start 5% ringer lactate, about 20 to 40 drops per minute, and then dilute an ampoule of 30 milligram of pentazocine or fortwin with a diluent like normal saline or distilled water, and similarly dilute an ampoule of diazepam. So we have to prepare these 2 ampoules and 10 ml of diluent, and we can administer 1/5 of each drug slowly in bolus from through the tubing of the infusion line, and then we can use rest. So we have to keep the drug aside the patient, and we have to make it well charted. That is most important, and ensure that the pains are optimal. It should be at least 3 to 4 in 10 minutes, and if necessary, we can augment the pain with 2 units of oxytocin simultaneously to progress the labor. We have to observe the progress of labor by partogram, because it is a single sheet of paper. We can see many things: maternal condition, fetal conditions, the cervical dilatation, and the fetal descent, along with what are the medications we are using during labor. And when the patient is in advanced labor, the fetal head pressing down on the pelvic floor, the patient starts complaining of severe pain or bearing down sensation. At this time, we can again use tramadol or compose, or sometimes we can use injection ketamine if required, but rarely we do use in our labor room setup. The anesthesia during labor, the proven obstetric analgesia is epidural analgesia, and in places where epidural analgesia cannot be provided, tramadol is a centrally acting non-opioid analgesic which has been used as a labor analgesic. Ketamine, a dissociative anesthetic, is gaining popularity as it provides excellent pain relief and pain satisfaction. Epidural analgesia is that the patient needs to be counseled properly. There should be no deformity in the spinal cord. And the next important thing, that the patient should be counseled that the labor duration may be progressed. So this is important, one of the side effects. Otherwise, the complications are not there with the epidural anesthesia. Coming to the clinical evidence, there is one important study which is published in the paper South Asian Federation of Obstetrics and Gynae in 2009, and they have compared that the use of these drugs in priming gravida. In the study group, they have used programmed labor, and controls, they have not used this programmed labor, and the sample size is 200, and they have come out with the conclusion that there's a significant difference in the mean duration of active phase of labor between the case and the control. That is 3.5 hours, and in controls 5.2 hours. The mean rate of cervical dilatation is 2.5 centimeter per hour in the study group and 1.2 centimeter per hour in the control group. Mean duration of second stage of labor is 26 minutes in the study group, whereas it is 48 minutes in control groups. And coming to the mean duration of third stage of labor, blood loss is 3.5 minutes, and in control it is 15 minutes. So there is excellent pain relief and the progression of labor also. This is very much important paper, and all these are parameters which is supporting this study. Coming to the complication, the side effect observed more or less, it is equal in both the cases and the control group, and there are some drug-related complications which may be very few when you are using these drugs. So again, the results are the same as I've described: the rate of cervical dilatation, the duration of active phase of labor, the duration of second stage of labor, all these are less. And majority of the patient in both the groups delivered vaginally, and 86% of the patient in the study group had pain relief as compared to 22% in the control group. So it is statistically significant. And the cases has significantly more drug-related side effects like nausea, vomiting, drowsiness, and which subsided after 12 hours. So we have to balance about the benefit and the risk in these patients. So again, this is a charted, the diagram which shows that the antispasmodic reduced duration of the first stage of labor by an average of 74.34 minutes in compared to the control group. So So again, this is the same paper where there is a comparison between the antispasmodics versus control group. This is basically a Cochrane database systematic review, and they have studied the outcome, duration of the first stage of labor, duration of second stage, third stage, total duration of labor, and the rate of cervical dilatation, and all these had a significant effect in the study group than the control group. So a single dose of 16 milligram valithromat bromide was administered via intravenous route in randomly selected 35 nulliparous and 37 multiparous women. This is a prospective randomized trial which is done in Turkey, and the study concludes that the median time from the complete cervical dilatation to the delivery was 20 minutes in the group received valithromat bromide and 25 minutes in the group that didn't receive valithromat bromide. So this concluded that the valithromat bromide significantly shortens the second stage of labor in nulliparous women. And this is again some of the side effect which is related to these drugs, but it is not very much statistically significant. Again, coming with the one of study, there is a rotavirin hydrochloride versus valithromat bromide for cervical dilatation in labor, and one group received rotavirin and one group received valithromat, and they have shown that the headache and cervical tear, they are less in the valithromat group. So with this, they have monitored the labor in the partogram, where we have all the general information about the patient, the fetal condition, progress of labor, and maternal conditions. And now it is replaced by the WHO Care Guide. We can see that the WHO Care Guide, what is the advantage of this? Because it is developed to improve every woman's experience of childbirth and to help ensure the health and well-being of the woman and their babies by facilitating the effective implementation of the WHO intrapartum care recommendations. And this tool establishes essential good quality and evidence-based clinical care in all the settings, and it expands the focus of labor monitoring to non-clinical practices that promote a positive childbirth experience for every woman and baby. So here, one thing is added, that is shared decision making. So whatever the patient is going through and what is the progress of labor, every time it is shared with the companion and the patient, and again, the patient is involved in her progress of labor and in her decision making, whether she needs a further trial or what she has any problem or not. So this is very much important component of WHO Labor Care Guide. So what are the interventions when the patient is almost at the end of the second stage? The patient should choose her own birthing position that is most comfortable. But yes, for the delivery, upright position is important, and propped up position is required. And then selective episiotomy should not be given. That is the recommendations. We should give episiotomy in only some cases when you are planning for instrumental delivery, or where there is a outlet obstruction, or sometimes there is a shoulder dystocia, or there is a very, very preterm baby, or there is a breech presentation. So in some cases only we can use episiotomy. Otherwise, some minor degree of tear is always accepted in these cases, because we know that long-term complications of the perineal trauma in these patients. So these are the interventions that are recommended during pregnancy. That is upright position during delivery, selective episiotomy, use of prophylactic oxytocin for management of third stage of labor, delayed cord clamping, and control cord traction with counter traction to deliver the placenta. So what is the recommendations? You know that. And what is not recommended is coaching the mother to push. We should not tell the mother to push. Perineal massage in the second stage of labor is not indicated. And yes, the fundal pressure during the second stage of labor, it should not be given. Nowadays, we know that it is very, very dangerous for the patient also and for the baby also, but still some of the nurses, midwives are using this in their practice. So we should make them aware by your talks and your camp. So coming with the conclusion, what are the advantages of the intrapartum care? It shortens the labor with substantial pain relief. It helps in significant amnesia of painful events of labor. Average blood loss is less. The duration of all the 3 stages of labor was markedly reduced. Obstetric management is simplified, and lowering of the incidence of operative deliveries. We are all struggling for decreasing the rates of cesarean section And in most of the private and institutional deliveries, we have seen that the cesarean section rate is it is around 60 to 70%. So with this, with the proper intrapartum care and using all the pillars and following the WHO guide, we can help our patient. And also the ROPS's criteria, we know that there are 10 criterias, and especially the primary gravitas cesarean section is increased nowadays much more. So we can take these patients and then we will follow that why in these patients the cesarean section is increased, and all these practices, if you can change these practices, and we can see there's substantial decrease in the cesarean section rate in these patients also. So neonatal mortality was similar in the control group when we see in both the cases. So ultimately, the decision making is very much important, and both the mother and the fetus is very much important. Your goal is to achieve a healthy mother and a healthy newborn by your good intrapartum care. So as a OBGYN specialist, we have to ensure better life. Thank you so much for a patient hearing. And with this, I welcome you all for first Endometricon 2024 conference, which is conducted by Varanasi Society of India with the ESI Society, Kolkata. And all are welcome on 21st and 22nd December. So please be there, and we are here to welcome you all. Thank you, madam. Thank you so much, chairpersons.
इसमें 34 weeks आ
Ishita
रहा है
has joined.
तो थोड़ा सा बेबी साइज बड़ा है 676
Requesting chairpersons for their expert comments, Dr. Uma Jaiswal and Dr. Ishita Awasthi.
Ishita is not here, kya?
Yeah, Uma ma'am, yes.
Ishita is
Sangeeta,
there?
very complete and very comprehensive
Very informed.
delivered
Yeah.
talk.
Thank you, madam.
At the end, we need a healthy mother and a healthy baby. You have given the complete outstanding talk. Ishita is there? Dr. Ishita is there? No. So thank you, Dr. Sangeeta. It is a complete, comprehensive talk for joyful intrapartum care. At the end, we need a healthy mother and a healthy baby. So, with the joyful mother care, all the pillars we use, we have a healthy baby and healthy mother. The timely intervention is must with the proper guidelines, and labor care guide should be mentioned in all the cases. Thank you so much. Dr. Anuradha Khanna ma'am, आप
Yeah,
बताइए अपने experience.
definitely I will say something.
Yeah, ma'am.
मैं तो गाइडलाइन क्या है कि
37
गाइडलाइन ये है कि आप पेशेंट हो और वो आपको पेशेंट बन के सोचना है कि ये मेरा शरीर है, ये जो मेरी पेशेंट है। जब आप खुद उसको अपनी जगह रख लेंगे, आपको सारी गाइडलाइन याद आ जाए, सारी गाइडलाइन। अगर आपने ये सोच लिया कि जो ये पेशेंट नहीं है, ये मैं हूँ, तो आपको उसकी रिक्वायरमेंट दिखेगी, एंड यू आर हैविंग such a good knowledge of your subject, of everything, the social, obstetrics has got a also known as social obstetrics. Social obstetrics हम भूल गए, social obstetrics हम भूल गए। whole lot is there। मेरे डिपार्टमेंट में एक प्रोफेसर की पोस्ट, जिसको मैंने बाद में डाउनग्रेड करके पोस्ट कर दिया असिस्टेंट प्रोफेसर का, दैट पोस्ट वाज ऑफ सोशल ऑप्टिक्स। तो सोशल ऑप्टिक्स में जितने डॉक्टर संगीता ने ब्यूटीफुली बताया कि हमको पेशेंट के हिसाब से क्या क्या देखना चाहिए, क्या क्या सोचना चाहिए, तो वो सब कुछ दिखने लगेगा। फिर इकोनॉमिक्स है, खाली ढेर ढेर अल्ट्रासाउंड करा लेने से कुछ नहीं होता है। आप बेसिक पैरामीटर्स याद रखिए, वो फंडल हाइट और एब्डोमिनल कट भूलिए मत, वो खुद ही बता देगा कि ग्रोथ रेट क्या हो रहा है, और पेशेंट को जाके लंबे लंबे समय तक पैसे खर्च करके लाइन में नहीं लगना होता है अल्ट्रासाउंड की। तो कुछ चीजें होती है ना जो हमारा क्लिनिकल सेंस है, वो जब से सोनोलॉजी आ गई है तब से वो मरता चला जा रहा है। मैं चाहती हूँ नहीं वो मरे नहीं, वो रिवाइव रहे, वो जिंदा रहे। हमारे समय में जब ये सब नहीं थे तो हम लोग इंची टेप से काम करते थे, और अभी भी करना चाहिए, एब्डोमिनल गर्थ के लिए भी और फंडल हाइट के लिए भी। तो ये सब चीजें हैं। और डेली फीटल मूवमेंट रिकॉर्डिंग DFMR वो बता देता है कि हाँ, अगर मोर देन 10 आवर्स का मूवमेंट विद इन 10 आवर्स हो रहा है या 1 आवर में कितने मूवमेंट है, आफ्टरनून में कितने 1 आवर में मूवमेंट है, रात में कितने 1 आवर में मूवमेंट है, एंड इट इज मोर देन 10। ये आपको बता देता है कि उसका बायोफिजिकल प्रोफाइल चल रहा है। So we are nowadays just not using the basic things and just jumping on fetal medicine, fetal ultrasound, वो मुझे थोड़ा कम पसंद आता है। और दौड़ के जरा भी अनोमली हुई नहीं कि CHA, अरे उसका टेस्ट थोड़ा भी, कल ही इक्वेशन करा के आई और उसकी वैल्यू निकली कि हाँ उसके रीनल मालफॉर्मेशन कुछ था, NIPS उसका नॉर्मल था, लेकिन बच्चा अबॉर्ट हुआ, उसका CGHA हो गया। और कॉस्ट मैंने पूछी, बेटा कितना कॉस्ट आया, बोलता है मैडम 32,000 रुपए, और क्या निकला, नो एनोमली। तो दिस इज एंड ही वाज अ मिडिल क्लास पर्सन। तो ये सब चीजें, जमाना आ गया, इंट्रापार्टम केयर कर रहे हैं, डॉक्टर संगीता ने ब्यूटीफुली बताया। तो हमको केयर वैसे ही करनी है जैसा उन्होंने बताया, लेकिन ये सोच करके कि ये मेरा शरीर है। लेबर रूम में जो भी रेजिडेंट, सीनियर रेजिडेंट्स पोस्टेड होते हैं, या हॉस्पिटल में जो भी हमारे ट्रेन डॉक्टर्स पोस्टेड होते हैं, तो उनको हमेशा ये रियलाइज करना चाहिए कि ये मेरी बॉडी है और मैं उसको ट्रीट कर रही हूँ। सारे आंसर, सारे गाइडलाइन सब सही जाएंगे। थैंक यू वेरी मच डॉक्टर उमा फॉर आस्किंग मी टू से समथिंग।
Thank you.
वंदना मैम, आपकी कोई इम्पोर्टेंट लाइंस या यू वांट टू गिव अ कमेंट? वंदना मैम, आर यू देयर? मैम अपनी बॉडी तो सोच रही है, साथ में सोचना है कि वैसे भी मेरे ही खर्च हो रहे हैं, तब वो ज्यादा अच्छा ध्यान रखेगी।
एग्जैक्टली, सोशल
Yeah.
ऑप्शन कहती है।
Yes. Thank you so much. It is a complete comprehensive talk, Dr. Sangeeta.
Thank you,
Anybody,
Dr. Thank you
Dr.
all.
Kumkum ma'am, Manisha di,
Yes.
सबको
Fourth way-
एंडोमेट्रिकॉन में आना है।
आ रही हूँ मैम, आ रही हूँ।
हाँ, सबको
Dr.
लाइए।
Vaishali,
Dr.
Yes.
Vaishali is also
Dr.
coming.
Vaishali, happy birthday and best wishes for your future endeavor.
Thank you.
Thank you so much for inviting me. Thank you, Anuradha ma'am, मेरी टीचर, मेरी गाइड,
Thank you.
मेरी एवरीथिंग।
Anuradha,
तो
Thank you
मैम
very
से मैंने बहुत कुछ सीखा है,
Thank you.
बहुत कुछ।
your
आज भी वो केस याद है मैम, जो सेकंड बेबी जब
जब दिसंबर
सेकंड
में आते हैं तो
व्हाट्सएप
मिलते हैं
लगाया था
आपसे।
रेखा दीदी ने, याद होगा आपको केस? बेबी नहीं बचा, रप्चर हो गया। तो हर चीज हमेशा याद आती है, और हमारे पुराने एक्सपीरियंस है उससे हमें सीखना चाहिए। और हमें बेसिक्स तो भूलने नहीं है बिल्कुल भी, कि हमें फीटल हार्ट कहाँ मिल रहा है। वो हमें हमेशा पेट छूना ही है, एब्डोमिनल गर्थ देखनी ही है, फंडल हाइट देखनी है, हेड की पोजीशन क्या है, फीटल हार्ट काउंट मेरी क्या कह रही है, और टाइम देना है, 5 मिनट्स देना है उसको, 1 मिनट पूरा देके उसको देखना है, बस ये ध्यान देना है। थैंक यू सो मच। हम तो पुराने वाले डॉक्टर हैं मैडम, आपने जैसा सिखाया।
या थैंक यू अनुराधा मैम, आपसे इतनी सारी बातें सीखी है आज हमने। एंड सोशल ऑब्स्टेट्रिक्स ट्रूली इज अ बिग बिग कंपोनेंट, एंड बीइंग प्रैक्टिकल, टचिंग द पेशेंट, फंडल हाइट, ऑल दिस इज सो इम्पोर्टेंट। और
उसका रिलैक्सेशन बहुत है। जैसे पेशेंट के पास जाओ, उसके पेट पे हाथ रखो, उसकी आंखों में आंखें डालो, 90% वो ठीक हो जाती है।
बिल्कुल
और
सही।
फिर आप उसको अच्छे
पेशेंट
से बोलोगे।
सेटिस्फेक्शन मैडम बहुत जरूरी है इसके लिए।
हाँ,
अगर छुआ तो उसको सेटिस्फाई हो जाती है वो, कि मेरी
बस
डॉक्टर ने मुझे देखा, पल्स पे हाथ
बस
रखा पहले, आई का पैलर चेक किया,
हाँ।
जब लिटाया तो फंडल हाइट खुद देखी, और फीटल हार्ट खुद सुना, बस 3 चीजें खुद देख ली, तो बहुत ही ज्यादा अच्छा है।
I feel कि reassurance all through the labor is very important,
या
along with the birthing companion. In
Yeah.
India, there is no अभी trend नहीं है birthing companion का, but we should slowly introduce this birthing companion.
लेकिन मैडम प्राइवेट सेटअप में हम लोग बुलाते हैं, प्राइवेट सेटअप में हम लोग बुलाते हैं कि जिसको आपको चाहिए, हस्बैंड को बुलाना है, मदर इन लॉ को, मदर को, सिस्टर को, तो हम लोग बुलाते हैं अपने सेटअप में।
मदर
नहीं,
इन
नहीं,
लॉ को
बुलाते
कुछ लोग
वो
मैम,
बुलाते
कुछ लोग
नहीं
अभी भी मदर इन लॉ को चाहते हैं। कुछ आजकल बच्चे कितने हैं, 1 या 2?
इसके अलावा I think reassurance is very much essential, and
Yes, ma'am.
we always encourage them to have water and walking around and positioning, and we should not make the patient
Down.
be on labor table for long.
Yeah.
Yes, ma'am.
Make the patient on table only when she is actively going to deliver. मैंने
Yes.
देखा है कि keep on patient on table for long, the patient gets exhausted. So that should
Very
not
true.
Women should be given
Change in
respect.
posture.
That is most important, madam. The woman should be
Change
given
in
respect.
posture.
Should be
She
given
should-
dignity. Their autonomy, preferences, the cultural values, everything should be respected during the postpartum period.
And a pediatrician and an anesthetist
Yeah.
on a phone call away is always very, very
Yes.
fine.
Yes.
That
Very
keeps yourself, you are reassured. Yes, pediatrician is there. Yes,
Music system in the labor room. Kumkum Didi.
Huh?
Music system in the labor room can
Yes,
be
it is also a good option. Yeah.
patient.
म्यूजिक
Like
सिस्टम एंड मैम टीवी का जो आप कर रहे हैं या कुछ वीडियोस दिखाइए उनको जो उनके
टीवी नहीं
लिए
तो कम
अच्छे
से
हों
कम म्यूजिक
हाँ
सकता है
Light
तो
music, background
डॉक्टर
music.
के लिए
Ball
Yeah.
and let's sit on the ball, exercise.
Yeah.
So
और
Yeah.
कलरफुल थोड़ा सा वॉल वगैरह रहे एकदम ड्राई नहीं रहे थोड़ा सा अच्छा लगता है उनको
accompanying companion Kumkum ma'am has said it is
I
so
wanted to
important.
say happy birthday to you.
Oh,
I thought
thank
I
you.
would.
यस
Thank you.
Now I think you should start celebrating your birthday. People at home must be waiting for you.
Yeah. Yeah.
It's a big celebration with all of you. I'm
Yeah.
truly really so lucky कि आज के दिन I got to meet all of you.
Wish you success in your upcoming election.
Yes, ma'am. Thank you, ma'am. Thank you. And about Sangeeta ma'am's talk, I would just like to say that what a fantastic talk you have given, covering all the aspects and your own personal viewpoint about the process. And being the head of department of BHU at such a young age, Dr. Sangeeta, I must really congratulate you and all the best for your upcoming conference.
Yeah.
And
You have to come, Dr. Vaishali. You have to come with your
I will be
students.
coming. Yes, I will come and आप सबसे मैं personally मिलूंगी.
Yeah.
There, I'll.
Thank you. All are welcome.
Thank you so
Honor
much.
Society is
Thank you so
always,
much.
always the star.
Thank you.
Bye bye.
Thank you.
Bye.
Bye.
Bye bye.
Bye. All
Namaste,
the
ma'am.
best.
And we would like to thank each one of you, all our guests of, both our guest of honor, Dr. Anuradha, Dr. Ranjana Khanna, and our speaker, Dr. Sangeeta, our chairpersons, Dr. Manisha, Dr. Kumkum, Dr. Uma Jaiswal, Dr. Ishita, and of course, BSV, who has supported us, our Dr. Aarti Evle, our MOC for today. And all the attendees who have logged in, a lot of people have logged in for today's webinar. And I'm sure they'll all benefit by the advice, the points given by all our senior faculty. So, we truly humbled with your presence. Thank you very much.
Thank you.
Namaskar.
Namaskar.
Good night.
Going to leave now.
Okay. Yeah. So really bye
Thank you,
everybody and
Vaishali.
Thank you all
Thank you.
from POJS also. Yeah. Thank you, Dr. Sangeeta Rai.
Sangeeta ma'am, Varanasi, I'll come on Sunday morning.
Great.
Saturday night, I'm reaching late.
Vaishali. Okay.
Saturday night, I'm reaching, and Sunday night, I'll leave.
Sure.
So, Sunday ke din-
We are there to welcome you. Please.
Thank you so much.
I am also planning to come to Varanasi.
Wow,
doctor.
great, madam. Please come. It'll be
Looks like a
nice
very
meeting you.
interesting
So
topic.
only a 2-hour journey from Allahabad to
Yeah.
Varanasi. So
अगर
we'll
समय तक
plan
नहीं होती
same day.
Yes, madam. All my scientific madam topics is always there in the
Come on
website.
Saturday
It is
afternoon
displayed.
and stay.
Yes, ma'am. So can you go through the topic, and it is very good, important national conference, madam. All the topics they are covered regarding infertility, adenomyosis, fibroid, endometriosis, everything, madam. So I am trying my best to deliver the best from all the
Who
greatest.
is in charge of the, I don't know,
For workshop, it is, ma'am, around
for the
3,000.
abstracts.
Just a sec, I'll just take your leave. So bye
7,000,
everybody.
madam. 7,000.
Bye. And thank you all for coming over. And yes, I'm having one more program over there. So I'll
Yes,
just
Dr.
take
Meenakshi.
your leave.
Thank you.
Yeah,
Bye,
thanks,
Meenakshi.
Dr.
Thank
Sangeeta,
you.
Dr. Uma.
Yeah.
Just next week, December में ultrasound
Ma'am, it is
लेना
on the website Endometricon 2024. Please see. Yeah. Everything is there, ma'am. Or you can call me.
Yeah.
Bye, Dr. Vaishali.
Bye. Bye.
Happy birthday once again.
Bye, Kumkum ma'am. Bye.
Bye.
Bye, 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 Vaishali. And thank you for having me.
Ma'am. Bye. Bye.
Shows respected visitors.